Thank you for the nice introduction, Gary, and thanks for the opportunity to present on behalf of all the Project Baseline Health Study investigators and participants today. I'm going to do something a little different. I'm not going to tell you a story about a research project that was designed, conducted, and the results are now available. I'm going to describe for you the both design and the ongoing conduct of the Project Baseline Health Study, a little bit of what we've learned, and a little bit of where we're going. These are my financial disclosures. They can be seen on my faculty profile website. For this particular talk, I have research funding to support my salary from Verily, the sponsor of Project Baseline Health Study. Well, as you all know, we have important transitions that lead from a healthy state to a disease state. And unfortunately, many of those transitions are very difficult to understand, both pathobiologically, but also very difficult to understand when they occur in our life course, and therefore make the potential prevention, detection, and treatment or prevention of disease very difficult. The Project Baseline Health Study is a longitudinal cohort study that is a partnership between Verily, or formerly Google Life Sciences, Stanford University, and Duke University. And we've affectionately had the tagline that Google has mapped the world, now let's map human health. This is a shot of the Project Baseline Health team, obviously before the pandemic, a really tremendous, dedicated group of research staff, fellows, and faculty that have implemented the conduct of the study here at Stanford. And like Gary eloquently said, I really miss Sam. Sam was the visionary, along with Rob Califf and Andy Conrad, who came up with the concept of the Project Baseline Health Study. And I know I speak on behalf of all of the staff and the participants that we're working hard to make this project a success, to represent the legacy of Sam. Well, many of you may have been involved with observational longitudinal cohort studies in the past. There are many examples of those. The Million Vets Project in the VA, looking at 1 million vets to identify genetics of disease. There's the UK Biobank. There's All of Us. And all of these observational cohort studies have to ask themselves very important questions in the design. How broad a population do you want to have and represent in your cohort? How deeply do you want to collect information on each of those participants so you fully understand their phenotypic expression of both health and disease? And then finally, over what period of time do you want to follow these participants? Some follow participants for an incredibly long period of time, like the Framingham Heart Study. Some people want to enroll millions of patients. In the Project Baseline Health Study, we wanted to focus on the depth of the evaluation of our participants. So we had a relatively modest number of participants, a planned follow-up for only 5 to 6 years, but a very, very deep collection of information on each of those participants. Well, what are the objectives of the Project Baseline Health Study? And they're really multiple, and it's not just around disease. First, we wanted to develop a set of scalable and standardized tools for acquiring, organizing, and analyzing a broad array of clinical, biological, as well as environmental and socioeconomic factors of these participants. We also wanted to evaluate approved as well as investigational wearable and passive sensors, a very important aspect that you heard from Gary about the techniques and strategies used by the PHIND Center in many of their studies. We wanted to be able to create a data set encompassing a wide spectrum of phenotypic measures that was easily accessible. We wanted to identify biomarkers of disease related to transitions, primarily around cardiovascular and cancer, two of the most common diseases that lead to morbidity and mortality. And then finally, we wanted to create a dynamic and comprehensive platform to understand both population as well as individualized personal health and clinical care. In the Project Baseline Health Study, we set out to recruit a representative population of the United States based on the most recent census statistics. We wanted to enroll approximately a third of the participants who were normal or had no reported history of disease, about a third of the participants that had prior cardiovascular or at high risk for cardiovascular disease, and then about a third of the participants with either known cancer, as you can see, lung cancer and breast or ovarian cancer, or had known traditional risk factors for an increased risk of those particular cancers. Well, overall, to date, we have enrolled 2,500 participants in the Project Baseline Health Study, about 1,000 participants here at Stanford, 1,000 participants at 2 sites in North Carolina associated with Duke University, and 500 participants in a research center in Southern California. Here's an example of the types of information that we're collecting on each of these individuals during their initial study visit, which is on site and lasts 2 days, about 6 or 8 hours a day. So it's a really, really intense commitment these participants are making. And we're going to talk a little bit more about the ways that we have continued to engage those participants over time. So they have a comprehensive assessment. We also then have surveys that they can do online at home, both initially at baseline, as well as regularly, monthly, and quarterly throughout the study conduct. We then arrange annual follow-up visits on site for a comprehensive 1-day assessment. And then we have continuous monitoring and reporting using an investigational watch, as well as a sleep sensor to collect data from nighttime and sleeping behaviors. The amount of data that we're collecting is about 6 terabytes of data on each participant at baseline and then annually. And so we had to think very carefully about how we were collecting that data in an efficient mechanism, how we were organizing those comprehensive data sets that are very discrepant in the types of data that you're collecting, both stagnant as well as continuous and repeated. And then finally, we wanted to make sure that we had a platform by which we could activate those data to either help in the diagnosis, prevention, or treatment of disease in the future. Well, as I mentioned already, the collection has been absolutely tremendous. 6 terabytes at baseline and about the same amount during the annual visits and routine follow-up. So an incredible volume of data that needs to be collected and then organized across these multiple domains that you can see here of the different data types that we've been collecting. We're using the Terra Platform to store a lot of the clinic data so that investigators at the centers at Stanford, at Duke, can access those data. And then we have a comprehensive governance process to allow access to additional data sources such as the watch, the sleep data, and the biosample repositories that we're collecting and now processing. And then finally, activation on those data. We want to be able to understand both what health looks like, as well as try to predict the transition from health to disease. And we're actually thinking right now about taking some of these data and rewriting the textbook of some of the simple assessments that we do in routine clinical practice all the time. We're learning an incredible amount about a very simple thing such as heart rate, and I'll show you data as an example of that in just a moment. But as I mentioned, the commitment to the Project Baseline Health Study is truly enormous. And we no longer, not only in Project Baseline, but in clinical research in general, we can no longer think of patients as subjects in research or simply a bystander in the research process, but really participants as partners. And we have engaged participants in the entire process. We had advocacy groups that helped us design the workflows for the participant engagement on campus. We try and be very appreciative of their commitment with annual exclusive community events. And then we have set up a comprehensive process to return results. Now, returning results that are clinically validated, like CLIA labs, for example, is relatively straightforward. But when you're collecting research grade information, the process by which you share that information needs to be thought through very carefully. But we know one thing for sure: participants are eager to get as much information as they possibly can. And as you think about your own research programs, I encourage you to think about what I call the 3 E's in participant engagement: engage, educate, and empower. And we hope that this will help long-term retention in clinical projects. Well, how are we working to activate this clinical data? Well, if you're interested, we have published the first baseline description of the Project Baseline Health Study in Nature Medicine last summer. We're now starting to form 3 working groups around cardiometabolic issues, mental health issues, and return of results issues. It's really staggering the amount of data that represents 6 terabytes. And if you just look here, you can see that in the 2,500 participants that have gone through mostly their second annual visit, obviously things were slowed down with COVID, we now have 8.7 million plus hours of study watch wearing, over 6,500,000 biospecimens. We've had squeeze and finger grip tests with hundreds of thousands of data, and I can keep going on the amount of information we have across these various domains. Here are some of the baseline demographics of the 2,500 participants broken down by the 4 sites. If you look at the right-hand column that I've highlighted, you'll see that in fact, we have 55% of the participants are women. And we have a racial ethnic breakdown that not necessarily matching the census in each site, but across all sites, fairly closely resembles the recent US Census population, with 60% white, 16% Black or African American, 10% Asian, and nearly 12% Hispanic. I'd like to share with you just some of the data that we've collected recently and we've started to analyze. These are data that are showing the proportion of metabolic syndrome based on the National Cholesterol Education Program. On the right-hand side, you can see the proportion of patients that have metabolic syndrome based on the NCEP criteria. But when we look at the Project Baseline Health Study, you can see that above the 0 line, there is a fair proportion of the population that has many characteristics similar to the metabolic syndrome, but don't meet criteria. And this is a patient population and a participant group that we want to analyze more to understand better. We're also looking at DNA methylation to understand how DNA methylation corresponds to your age. Now this is not a unique or new observation, but what we've identified in the Project Baseline Health Study is that there's a number of participants that are fairly well above or below the blue line. And we want to understand, why do those participants have methylation patterns that are very discrepant from their chronological age? And finally, I mentioned resting heart rate. We're doing a number of analyses to correlate associations of resting heart rate to another number of other biomedical parameters, activity levels, socioeconomic factors. And here you can see the participants based on the watch who had, on average, one more hour of activity a day had a lower average heart rate of 2 beats per minute. Think about it. That equates to almost 650,000 heartbeats a year. So a lot more to learn. But we are still learning about how we are going to collect, organize, and activate on these data because of the sheer volume, as I mentioned already. But the good news now, in working with both clinical investigators, molecular scientists, as well as quantitative scientists, we have a deeper understanding of the data and an ability to perform analyses across these key domains. And finally, as I wrap up here, we're very excited to continue the efforts on the Project Baseline Health Study. We think that it is a unique observational cohort study with the continuous parameters, the very deep phenotyping that we've achieved, and our ability to connect across the research community, the participate community, as well as other funding mechanisms in the future. Thanks very much for having me. I've appreciated it.
Excellent. Thanks so much, Ken. What a pivotal study, and thanks for sharing this update. So this is such a monumental data set to have access to. I think originally the plan was to be able to have qualified data scientists, other investigators, to also be able to share in mining this data at some point in the future. Is that still the case?
Absolutely, Ryan. Our ultimate goal is to eventually make this an open source platform for people to work on the data. We're doing it in a phased approach. Right now, we actually have some of the clinical data and other ancillary data sets available on campus through the Terra Platform. And we have a quantitative scientist from the Quantitative Sciences Unit run by Manisha Desai, a woman named Rong Lu, who can help investigators connect with the data, understand the platform, and start doing some analyses. And then, as I mentioned, we have a series of working groups that's organized around cardiometabolic issues, mental health issues, and returning of results issues. And people can reach out to us if they have any questions.
Excellent. Oh, yeah. And kind of building on that question, within the Terra platform, are you then also able to combine data sets maybe from the All of Us study or UK Biobank as well? I remember seeing plugins on the platform, but I haven't tried it myself.
Yeah, we haven't formally created those plugins yet, but we do have investigators that are trying to take data that we have from a Project Baseline Health Study and then try and validate some of the observations on other data sets that we have here, perhaps through the Population Health Sciences Center or other clinical databases that people have, such as the NCEP database, CMS databases, Medicare, and also payer databases.
Excellent. And I guess you may have covered in your slides, but what is the age range of the baseline participants?
Yeah, so per protocol, we only enrolled people over the age of 21. And we had a really nice representation across the age groups from 20 to 40, 45, 45 to 60, and over 60. And I apologize, I don't remember what the median age and the interquartile ranges are, but it is in our Nature Medicine paper if someone is curious to look at it.
Absolutely. And I guess just one more follow-up on the data. Did we have an idea of when the data will be available to others?
So people can have an opportunity to explore the Terra platform even now. If they also want to have more comprehensive and deeper dives into the data, then we do have a proposal template that we can provide to people for them to fill out a summary of what they'd like to look at, what questions and hypotheses they have. And then we review that in one of our working groups and we prioritize it. It's also an ability for us to connect people with similar interests so that we're not analyzing the same thing across multiple groups on campus here or at Duke or at Verily. And it also gives some of our young faculty, postdoc, and trainees opportunities to engage in team science across these institutions. And we've seen a lot of people having a lot of fun seeing data, analyzing data, and learning a lot from it along the way.
Yeah, absolutely. And also, I wonder about, your personal studies, how is this, having access to this kind of data shaped, what you're thinking about for your own group in the future?
Oh, well, I mean, I can answer that in a variety of different ways, right? One would be scientifically, and the ability to explore some of these issues, such as some of the wearable and digital technology we have about activity and sleep, heart rate, and other physiological assessments, is allowing me to think how to include some of those evaluations in other disease states. So I do a lot of work in atrial fibrillation, and the ability to think about how we could use wearable technology as we're exploring new therapies for atrial fibrillation couldn't have happened without some of the data I'm seeing from the Project Baseline Health Study. And then a second approach or perspective that I'm thinking about is the incredible ability to mentor our trainees, our postdocs, our young faculty on research questions and access to data to learn quantitative skills, learn how to write, and learn how to publish.
Absolutely. And yeah, I guess just one last question, looking at your initial results, do you see that it's possible to use wearable devices then for health monitoring? I know, there's always signal processing issues as well as other complications. So just curious your thoughts based on what you've seen.
Well, from the Project Baseline Health Study, we're just literally scratching the surface on this issue and many of the other things. So I can't answer it specifically from the Project Baseline Health Study, but I am a firm believer, having worked with the Apple Heart Study, having worked with other app-based technologies for patient care in clinical research domains, that I do think that we can work out the variety of issues that you've mentioned. One is obviously just the technology and the validity and fidelity of the data. We're getting there. I also know that we've been successful so far, but we have more work to do to understanding some of the privacy issues and data security issues, but we will get there. There's a lot of work to do, and we need a lot of smart people who want to explore and investigate this space.